Right now, somewhere out there, a patient with a highly contagious, completely drug-resistant superbug is just sitting in a crowded hospital waiting room.
Yeah, just sitting there.
Right. And they have a mild cough, maybe a slight fever, nothing really dramatic. But by the time they actually get called in to see a doctor, they've already exhaled onto the receptionist.
Yep.
They've shared an armrest with a pregnant woman, and they've passed that pathogen on to a tired nurse who is, just starting a 12-hour shift.
And honestly, that is the exact moment the battle is lost. I mean, the whole system is entirely reactive.
Right.
We literally wait for the fire to reach the most vulnerable building in the city, the hospital, before we even try to put it out.
It's crazy when you frame it like that, but what if we could have stopped them 3 hours earlier, like at their local pharmacy?
Yeah.
Or even just at a kiosk down their street?
That is the whole point.
Exactly. So, welcome to the deep dive. Today we have a highly specific, highly urgent mission for you, our listener. We are taking this massive stack of medical, financial, and public health intelligence. I mean, we've got decades of clinical data, World Health Organization reports, cutting-edge AI architecture, and we're looking at how you take all of that and transform it into a high-stakes, investor-facing pitch.
Right, because when you walk into a boardroom, full of venture capitalists and philanthropists and hospital administrators, you can't just read a list of app features.
Yeah, that'll put them right to sleep.
Exactly.
Yeah.
You are pitching a paradigm shift. You have to overcome their inherent skepticism about digital health.
And there is a lot of skepticism.
So much. You do that by pivoting away from the idea of just another medical app. You have to frame this as a critical piece of hardware infrastructure.
Okay, let's unpack this for a second. So you aren't pitching a symptom checker. You're pitching Dr. Maya AI and the PREMA Kiosk as essential biological firewalls.
A biological firewall. That is the perfect conceptual anchor for your audience.
I really like that phrase.
It works so well because just like a digital firewall isolates a corrupted file or, malware before it enters the mainframe of a computer network, PREMA identifies a contagious patient and quarantines them at home before they enter the physical hospital ecosystem.
Oh, wow. Yeah.
It's all about early identification, guided isolation at the neighborhood level, and ultimately saving global healthcare systems from total financial collapse.
So how do we structure this argument for you? We are going to walk you through the core strategy of this pitch today. We aren't just going to, dictate bullet points to you.
No, you need the context.
Right. We are going to explore the underlying science, the economics, the psychology that you really need to master to win over that room. Because you have to understand the why and the how behind every single claim you make on these slides.
And the tone you need to strike is, it's a delicate balance. It really is. Well, it must be visionary and compassionate, obviously.
Yeah.
But fundamentally, it has to be investor-friendly.
Right.
You are presenting this massive public health intervention, but it doubles as a sustainable passive income business model.
Okay, so let's dive into it. Let's start with slide 1, the opening hook of your presentation. The vision. So your core argument right out of the gate is that Dr. Maya AI and the PREMA Kiosk protects families before infections become pandemics.
Right.
But let me push back here for a second, just putting myself in the shoes of a super skeptical venture capitalist.
Go for it.
Starting the entire pitch with the word pandemic, isn't that a bit alarmist? I mean, how do you ground this immediately so investors don't just roll their eyes and think, oh, great, more sci-fi doom-mongering?
That is a very real friction point you are going to face in that room. The word pandemic carries a massive amount of fatigue right now.
People are just tired of hearing it.
Exactly. Yeah. So you immediately ground it in present-day infrastructure.
Yeah.
You acknowledge the reality of the room. You look at these stakeholders and you say, look, the world currently reacts to health crises only after they hit the emergency room.
Right.
And then you introduce the PREMA Kiosk as a decentralized healthcare ATM network.
A healthcare ATM. I love that analogy. It's so visceral.
It makes it tangible, right?
Yeah.
It's street-level infrastructure.
Yeah.
You tell them this is a rare chance to invest in a generational philanthropy project that actually actively generates commercial revenue while physically intercepting localized outbreaks.
So you move them from abstract fear to concrete, investable hardware.
Exactly.
Okay, so once you have them hooked on the vision with slide 1, slide 2 is where you define the problem. And the problem is the silent spread of infection.
This is crucial.
Because the greatest danger to public health doesn't look like a horror movie. It looks like a mildly symptomatic person running errands, right?
This is exactly where you need to explain the biology and the psychology of mild illness to your audience.
Okay, break that down.
Well, When someone is infected with a pathogen, there is an incubation period. Their immune system is, just starting to fight it off, but they might only feel a tickle in their throat or maybe a slight lethargy.
Just a bit run down.
Right. So what does human nature dictate that they do in that moment?
They power through. I mean, they take some ibuprofen, they go to work, they take the train, they hug their kids.
Precisely.
Oh.
And biologically speaking, they are already shedding the virus or the bacteria.
Wow.
This is the critical window of intervention. You really need to emphasize to the room that mild symptoms hide serious contagion.
So the danger is already there.
Oh, absolutely.
Yeah.
By the time that person actually realizes they are highly infectious, by the time the fever spikes and they finally decide to go to a clinic, they have unwittingly transmitted that pathogen to highly vulnerable groups.
Right, like the coworkers or the elderly guy on the bus or pregnant women at the grocery store.
Exactly. It's the invisibility that makes it so lethal.
The window to stop an outbreak isn't when the patient is on a ventilator. It's when they have a runny nose at the local chemist.
Yes.
Which actually transitions us perfectly into slide 3, which covers the specific looming threat that makes this technology not just a good idea, but an absolute necessity. You have to pivot the room to AMR, antimicrobial resistance.
Yes. And when you bring up AMR, you have to hit them with the sheer scale of the data.
Because it's massive.
It is. Because most people, even really sophisticated investors, they do not realize that this is already a silent pandemic happening in our homes right now.
Let's look at the source material on this for a second, because the numbers are staggering. Bacterial AMR was directly responsible for an estimated 1.27 million deaths globally in 2019.
Right.
And it was associated with nearly 5 million deaths. And by 2050, it is projected to cause 10 to 39 million deaths annually.
Which is just an unfathomable number. So to put that into perspective for your audience, you really need to take a step back and explain what AMR actually is.
Good point.
Because it's not some new exotic disease. It's the evolutionary process where bacteria, viruses, fungi, parasites, they change over time and they simply no longer respond to our medicines.
It's like the bacteria have hacked our medical system.
That's a really good way to look at it, because bacteria can actually share genetic material with each other through a process called horizontal gene transfer.
Wait, how does that work?
So they exchange these tiny loops of DNA called plasmids. So if one bacterium figures out how to survive an antibiotic, it can literally hand the survival blueprint, the cheat code, basically to a completely different species of bacteria.
Are you serious? To a different species?
Yep.
Wow, that is terrifying.
It is. And the consequence of that is that basic infections become incredibly difficult and sometimes impossible to treat.
So routine things become deadly.
Exactly. It makes minor injuries and routine medical procedures incredibly high risk.
Right. So if you are pitching this, you need to make it visceral for the room. An analogy that comes to mind, AMR is kind of like a termite infestation in the foundation of modern medicine.
I like that.
You don't see the house falling until the very end, right? But the structural integrity is secretly failing beneath your feet. Without effective antibiotics, things we just take for granted, C-sections, joint replacements, chemotherapy, basic appendectomies, they all become potentially lethal because the risk of untreatable post-op infection just skyrockets.
And beyond the human toll, remember who you are speaking to. You are speaking to venture capitalists and hospital administrators.
Right, the money people.
So you must speak the language of macroeconomics. The World Bank estimates that AMR could cause $1 trillion to $3.4 trillion in global GDP losses per year by 2030.
Wait, let's drill down into that number for a second. $3.4 trillion. How does a bacterial infection cause that level of economic damage? It's not just the cost of longer hospital stays, is it?
No. The direct hospital costs are just the tip of the iceberg.
Right.
The massive GDP loss comes from shrinking workforces. It comes from prolonged illness, pulling adults completely out of the labor market.
I see.
It comes from family members having to literally quit their jobs to care for relatives who are permanently disabled by these chronic, untreatable infections.
Wow.
It destabilizes entire global supply chains. You really have to make it undeniably clear to these investors that AMR is an economic crisis on par with a global financial crash, but one that is biologically driven.
Okay, so you've established the biological threat on slide 2 and the economic threat on slide 3. The next phase of your argument, slide 4, has to disrupt a core societal belief. And this is where you might actually make some of the hospital administrators in the room very
Oh,
uncomfortable
absolutely.
because you have to explain why hospitals themselves are inadvertently acting as infection amplifiers.
It is a really difficult truth, but it is central to the entire pitch. We view centralized healthcare systems as these pure zones of healing, right?
Of course.
That's where you go to get better.
But structurally, when panicked, contagious individuals travel to centralized clinics, those clinics inherently become reservoirs and distribution hubs for superbugs. The sources mention that colonization rates can reach up to 83% among patients and staff in these environments.
Yes. Just think about the actual physical mechanics of a traditional hospital waiting room.
Okay.
It is often poorly ventilated. You have a massive concentration of sick individuals sitting shoulder to shoulder with highly vulnerable people. So you have someone with a highly infectious respiratory bug sitting next to someone with a broken arm or an elderly person with heart palpitations.
Right.
And they're all sharing the exact same air, the same plastic chairs, the same door handles, the same reception desk.
So if I'm a patient who is shedding an untreatable pathogen, I'm basically coating the entire room in it before a doctor even calls my name.
Exactly.
Yeah.
Because of delayed triage, infectious individuals are just sitting in these common areas for hours.
Yeah, we've all been there, waiting forever.
And during that time, they're exposing healthy adults, children, and crucial healthcare workers to infectious risk long before they ever see a physician. So you have to look the investors in the eye and tell them, hospitals save lives, absolutely. But without intelligent early identification, they become threat vectors. They actively amplify the very outbreaks they're trying to contain.
That is a powerful pivot. So if the physical waiting room is the problem, the logical solution is to stop people from going there unnecessarily in the first place. Which brings us to slide 5 and the structural flaw in the whole system, the missing gatekeeper in healthcare.
Right. Healthcare systems are basically collapsing under the weight of diagnostic uncertainty.
Diagnostic uncertainty, what do you mean by that?
Well, when a patient feels sick, they completely lack reliable guidance on the appropriate level of care they need.
Oh, I see. Because if I wake up with, say, a pounding headache and a fever, I don't inherently know if I just need a paracetamol and some sleep, or if I need to speak to a pharmacist or a nurse, a GP, or if I have, meningitis and need to rush to accident and emergency right away.
Exactly. And because you don't know, and because you are naturally anxious about your health, human nature dictates that you default to the highest possible level of care just to be safe.
Right. Better safe than sorry.
So you rush to the A&E. Or you demand a same-day GP appointment. And this panic-driven behavior leads to a massive system overload from entirely avoidable consultations.
And the really dark irony here is who is currently acting as the gatekeeper intercepting all this panic? The sources point out that in a lot of primary care systems, it's the GP receptionist.
Yes, which is honestly a structural absurdity when you think about it.
It really is.
We have receptionists who often have zero formal clinical training, acting as the primary triage layer for a terrified public.
Yeah, they're just answering phones.
Right. And they are forced to make these split-second medical decisions over the phone about who actually gets to see a doctor today and who is told to wait. It's incredibly stressful for the administrative staff, and it's highly dangerous for the patient.
Okay, so here is where your investors are going to interrupt you. If they're paying attention, they're going to say, look, we know this is a problem. That's exactly why there are 1,000 symptom checker apps already on the market. Just Google it or use one of those digital health apps.
Right, the classic tech objection.
So for slide 6, how do you convince the room that this AI gatekeeper you are pitching is actually any different or safer than what already exists on everyone's smartphone?
This is a crucial pivot in the pitch. You have to totally dismantle the competition by explaining why existing symptom checkers are fundamentally flawed.
Okay, how do we do that?
The core argument here is that traditional digital health apps use these really rigid, fear-inducing algorithms that actually drive more traffic to hospitals, not less.
Wait, how so? If an app is supposed to triage you and keep you home, why is it sending more people to the emergency room?
It all comes down to liability. The companies that build these conventional symptom checkers are absolutely terrified of being sued for giving bad advice. So because of that fear, their algorithms rely on what is called generic safety netting.
So if I input a headache and a slight fever, what does the app do? Does it panic?
Basically, yes. It uses a very rigid decision tree. It says, if headache and fever, then advise emergency room.
Just immediately escalating it.
Yeah. It's a single symptom escalation model. It completely lacks context. It is this black box of code that has no clinical nuance whatsoever.
So it's covering its own tracks.
Exactly. It frequently frightens users. It might tell someone with a minor sinus infection that they could have a brain bleed and sends them rushing to the hospital just so the app developers can cover themselves legally. It over-triages massively.
Which completely defeats the entire purpose of keeping people out of the hospital waiting room.
Precisely. So you tell the investors, our current digital tools are not gatekeepers, they are funnels. They're pouring more anxious people directly into an already collapsing system.
That is a great way to put it. So moving to slide 7. What makes Dr. Maya AI different? How does it avoid this legal panic and actually provide safe triage?
Well, to explain this, you have to talk about provenance.
Yeah.
Dr. Maya AI wasn't built in a Silicon Valley vacuum by tech bros trying to, disrupt healthcare over a weekend.
Right.
It is the result of 50 years of real-world clinical, pediatric, and general practice experience.
Yeah, the sources dive into this pretty heavily. It was created by a physician, Dr. Kadialis Srivatsa, drawing on decades of hands-on experience in the NHS.
Yes. And the mechanical difference, the actual how it works, is that it utilizes a proprietary, color-coded combinatorial reasoning system.
Okay, combinatorial reasoning system. That is definitely a mouthful.
It is a bit dense.
Break that down for the listeners so they can explain it to an investor without sounding like they are just throwing around meaningless jargon.
Absolutely. So think about how a seasoned human doctor actually works. A rigid app just looks at isolated data points, right?
Mm-hmm.
But a doctor looks at the whole picture.
Right, they take it all in.
Exactly. Dr. Maya AI is built on the foundation of something called the Pediatric Assessment Triangle, or PE, which was developed back in the 1980s.
What exactly is the pediatric assessment triangle?
It's a rapid visual assessment tool that emergency physicians use to quickly gauge how sick a child is without even touching them.
Oh, wow. Without touching them.
Yeah. It relies on 3 points: appearance, work of breathing, and circulation to the skin.
Okay, so appearance, I'm guessing that means, is the child alert? Are they floppy? Are they making eye contact?
Exactly. And work of breathing. Are they grunting? Are their nostrils flaring? Are they having to use their stomach muscles to drag in air?
Right. And circulation.
Circulation is visual too. Is their skin a normal color, or is it pale or mottled or maybe a bit blue?
So a doctor uses this triangle to synthesize all that information instantly.
Right. If a child has a high fever, a rigid app might just scream emergency. But a doctor using the triangle sees a child with a fever who is alert, breathing normally, and has good skin color.
So they know it's fine.
Yes. The doctor knows this is likely a routine viral infection, not a life-threatening emergency. They're looking at the combination of symptoms and signs.
And Dr. Maya AI digitizes that exact clinical intuition.
Yes, that is the key. It evaluates combinations of symptoms and signs, basically mimicking a doctor's intuition to separate minor illness from serious risk and ordinary anxiety from actual danger.
That makes so much sense.
It doesn't just ask, do you have a fever?
Yeah.
It correlates the fever with the duration, the patient's age, associated pain, visual cues. This allows it to provide clear, calming risk guidance rather than generic, legally defensive panic.
And it communicates this guidance using a very specific visual framework. Which brings us to slide 8, the color-coded logic.
This is brilliant. It's a transparent, universal triage language. It empowers patients, and it dictates immediate public health actions. You really need to present this clearly to the room as a visual matrix.
Let's walk through the colors so the listener can pitch them. So first, red is for emergency escalation. This overrides everything else. If the AI flags red, you call an ambulance or you go to A&E immediately.
Very straightforward.
Then you have green, which is moderate concern. The advice here is to schedule a GP or nurse appointment within 24 to 48 hours.
Right.
Yellow is minor illness. You just self-manage at home or consult a local chemist.
But the true paradigm shift, the feature that you absolutely need to hammer home from both a public health and an investment standpoint, is the blue code.
Right, because in almost every other medical triage system in the world, red is the only color that really dictates immediate systemic action. Red means act now. But here, blue is the revolutionary feature.
It really is.
Because it literally tells people to stay away from the hospital.
This is the biological firewall in action. The blue code explicitly flags infection risk.
So the AI recognizes a pattern, say, fever, persistent dry cough, loss of taste, and instead of just saying, see a doctor, it triggers blue.
Exactly. And the immediate instruction for a blue code is isolate immediately, protect others, and seek remote advice or targeted medication. It actively overrides green and yellow. Wow. You need to tell the audience verbatim. Infection control is the first step in pandemic prevention. The blue code stops the superbug at the front door.
It stops them from getting on the bus. It stops them from walking into that crowded waiting room we talked about at the beginning.
It intercepts the contagion before it can spread.
Okay, so the combinatorial AI is brilliant. The four-color logic is a fantastic framework. But here is a massive sociological hurdle, and honestly, any smart investor is going to spot it immediately.
Yep, the access problem.
Exactly. An app on a smartphone only works for people who actually own smartphones. It only works for people who are digitally literate, who have reliable internet, and who speak the language the app was coded in.
Which leaves a lot of people out.
Right. If we are trying to stop a global pandemic, you can't just leave out half the population. How do we deploy this as actual physical infrastructure?
This is where you introduce slide 9, the hardware. The PREMA Kiosk.
Okay, tell us about PREMA.
PREMA stands for Personal Responsive Empowering Medical Assistance. This is exactly how you decentralize healthcare and bring clinical-grade AI directly to the streets, bypassing barriers of literacy, wealth, and language completely.
Paint a picture of this kiosk for us. What does it actually look and feel like if I walk up to one?
Think of it as the modern successor to the old public telephone booth. It's a physical unit that functions like street furniture.
Oh, cool.
It can be placed in chemist shops, rural village centers, busy urban markets, hospital lobbies, factory workplaces, and crucially, it features a voice-first interface that speaks over 30 languages.
You don't even need to be able to read to use it.
Exactly. Meaning a user doesn't need basic literacy to interact with it and get medical help.
And it's not just an iPad on a stand, right? The sources say it's IoT-enabled.
Right. IoT stands for the Internet of Things, meaning the kiosk interacts with physical medical devices built into it.
What kind of devices?
It can check a user's blood pressure, their blood oxygen levels, their temperature, and their BMI right there on the spot. It has thermal printers to instantly print out prescriptions or triage advice.
That's amazing.
It even has HD cameras that can examine rashes or throat inflammations for the AI to analyze.
But wait, what if it's placed in a rural area with terrible internet connectivity? What happens then?
They thought of that. It has offline fallbacks. The core AI can process the combinatorial logic locally inside the machine without needing to ping a cloud server.
Oh, that's smart.
Yeah, ensuring it works even if the local internet goes completely down.
This bridges the digital divide so perfectly. Because the best AI in the world is useless if the most vulnerable populations can't access it when they get sick.
Exactly. You tell the investors that the PREMA Kiosk creates local access for people without apps, people who cannot afford smartphones, or those who simply need a guided, voice-assisted experience to feel confident in their healthcare decisions.
Okay, so for slide 10, to really drive this home for the room, you need to walk them through the user journey. Show them how this hardware actively protects families in the real world.
You really need to tell a story here that every stakeholder can relate to. Just break it down into 5 clear steps.
Okay, lay it out.
Step 1. A person feels unwell. Let's say it's an anxious mother with a feverish child at 8 p.m.
A super common scenario.
Very common. Step 2. Instead of guessing what to do or automatically rushing to a crowded emergency room, she just walks down the street to the local PREMA kiosk at the corner chemist.
Okay.
Step 3. The AI instantly assesses the combination of the child's symptoms and vital signs.
So it takes the temperature using the built-in sensors, analyzes the breathing pattern she describes, looks at the timeline.
Right. And step 4. The AI correlates all these signs and flags, a bacterial infection risk, so it issues a blue code.
The biological firewall.
Exactly. Step 5. The mother is advised to take her child straight home, isolate, and use the system to call a doctor for remote prescribing.
The outcome here is profound. It changes everything.
Because she gets this clinical-grade advice before sitting in a clinic for 3 hours or before taking a crowded bus across town, her family, her neighbors, and her community are protected immediately. The firewall held.
And you must connect this micro-level story back to the macro-level threat of AMR for the investors.
How do you make that leap?
By keeping that infectious child out of the hospital, you aren't just protecting the neighborhood, you are protecting the healthcare system itself. Which brings us to slide 11. You are shielding the frontline workforce.
This is a critical beat in the presentation because doctors, nurses, pharmacists, receptionists, they are rightly hailed as heroes, but biologically speaking, they are subjected to massive, repeated viral and bacterial loads every single day.
Think about the physics of a nurse's shift. They are constantly moving from room to room. They are
Hmm.
breathing in aerosolized pathogens. They are touching contaminated surfaces all day. Even with PPE, the sheer volume of exposure increases their risk exponentially over time.
It's just a numbers game eventually. Right. If a highly lethal antibiotic-resistant superbug hits a hospital, the frontline workers are the first ones to fall sick.
And if the hospital staff is wiped out in the first wave of a superbug, who is left to treat the second wave?
Nobody.
The entire operational capacity of the healthcare system just collapses.
This is exactly what you tell the hospital administrators and policymakers in that room. By identifying infectious patients at the street level and instructing them to isolate, PREMA drastically reduces this avoidable exposure.
It acts as a shield for the doctors.
Exactly. It preserves the workforce, it stops staff from becoming patients themselves, and ensures hospitals can actually continue functioning during a severe outbreak.
Which brings us to slide 12 and the financial bottom line. If you are keeping people out of hospitals, you are obviously saving money. But how much money are we talking about here? How does this actually eliminate systemic healthcare waste?
The macroeconomics are staggering, honestly. A massive portion of current healthcare spending is entirely wasted on people who simply need reassurance. Those are your yellow and green codes.
Right.
Or people who shouldn't be in the hospital at all because they're highly infectious, your blue code.
The sources indicate that PREMA can intercept 25% to 40% of avoidable GP and A&E visits. That's a huge chunk of traffic.
Think about the operational cost of a standard A&E visit.
It's got to be high.
You have the administrative overhead, the nursing time, the physician's time, the physical resources, the lab tests that are often ordered defensively. It can cost hundreds, if not thousands, of dollars per visit.
Contrast that with the operational cost of a PREMA triage session.
It's pennies on the dollar. It's fully automated once the hardware is there. You tell the investors, by intercepting a third of these avoidable visits, PREMA radically lowers the cost of care delivery across the board.
It also stops something we discussed earlier, panic-driven antibiotic overprescription.
Yes, this is so important. When a doctor is completely overwhelmed with a waiting room full of anxious, mildly ill patients, they are under immense psychological pressure to just do something.
Yeah, to feel like they are treating them.
Often, that results in prescribing antibiotics for viral infections just to get the patient out the door so they can see the next person.
Which accelerates the AMR crisis we talked about.
Exactly. By filtering out the noise at the street level, PREMA gives doctors the time and space to make accurate, judicious prescribing decisions.
Okay, so we've covered the core public health and economic arguments. Now for slides 13 through 15, we move into what I call the investor hooks, the macro-level selling points that make venture capitalists sit up and realize the true scale of what they're looking at.
The really exciting stuff.
Let's start with slide 13, real-time epidemiological surveillance.
This transforms PREMA from a simple medical device into a national security asset. You present this to the room as the global biosecurity dashboard.
How does that actually work in practice?
Well, right now, how does a government health ministry know an outbreak is happening?
Usually when hospitals start reporting a spike in cases, right?
Exactly. They rely on syndromic surveillance from hospitals and lab results. A cluster of people get sick, they go to the hospital, tests are run, labs process the tests, and maybe days later, a report is generated for the government.
It's a massive lag time.
A huge lag. But because PREMA kiosks are processing symptoms instantly at the street level, a network of these kiosks acts as a massive, crowdsourced data miner.
Oh, wow.
The sources state that this network can detect geographic illness clusters up to 6 days earlier than traditional lab reports.
6 days. I mean, in the context of a fast-mutating respiratory pathogen, 6 days is an absolute eternity.
It is literally the difference between containment and a global pandemic.
Yeah.
If you see 50 blue codes for respiratory distress light up in a specific postcode over a 24-hour period, government health ministries have the actionable intelligence to lock down a neighborhood, deploy targeted resources, or distribute antivirals before the pathogen hits dense urban centers.
That is incredibly powerful. But, governments move slowly. If an investor wants to see rapid deployment and rapid returns, what is the commercial strategy? Slide 14.
For slide 14, you pivot straight to the micro-franchise model. PREMA offers a highly profitable, scalable deployment model with variants for every environment. You aren't just selling one massive, expensive machine to the government.
Right. The sources outline several variants: PREMA Home, Shop, Clinic, and Institutional.
So you break down the economics for them. You have the compact home unit for a few thousand rupees, designed for large households or apartment complexes.
Okay.
Then you scale up to the shop variant for local chemists, the clinic variant for GP waiting rooms, all the way up to the heavy-duty institutional unit for airports and major hospitals.
And the revenue model for these?
It is highly lucrative passive income. The math is simple but really compelling. If a kiosk in a busy chemist charges a tiny microtransaction fee for a consultation or for printing a prescription, just 10 users a day can generate significant annual revenue.
Just 10 a day.
Yeah, the sources cite an example of up to £18,000 annually per kiosk, just from moderate usage.
Wait, I have to push back here for a second. The outline mentions that this model creates local jobs through something called community health navigators.
Yes, it does.
But if this is an autonomous AI kiosk, why are we paying human beings to stand next to it? Doesn't adding payroll completely defeat the low overhead franchise model you just pitched?
That is exactly what a sharp investor will ask you in that room.
So what's the answer?
The answer is that the community health navigators aren't expensive medical professionals. They are local youth or former care workers employed at a very low cost, simply to assist the elderly, the physically disabled, or the highly anxious with operating the kiosk.
So they're facilitators, not diagnosticians.
Exactly. And their presence actually drives up the utilization rate of the kiosk, increasing the revenue far beyond their basic wage cost.
Oh, that makes sense. People trust it more if a friendly face is helping them.
Right. Furthermore, it creates a powerful community bond. It generates local employment while delivering healthcare, which makes the whole project highly attractive for government grants and philanthropic matching funds.
That is a very smart structural play. Okay, so moving to slide 15. There is one more crucial sociological barrier to address before you close the pitch. It's a hidden driver of pandemics that we rarely talk about, but it's absolutely vital.
Stigma.
Stigma. Because sociological barriers are just as dangerous as biological ones, aren't they?
Oh, definitely. People with heavily stigmatized infections like tuberculosis, HIV, or various STDs, they often hide from the medical system out of sheer fear of community judgment.
Right. If I think I have TB and I live in a tight-knit community, I might be terrified to walk into the local clinic and have the receptionist announce my name, or have my neighbors see me sitting in the infectious disease ward.
Exactly. And because they hide, they don't get diagnosed,
Yes.
they don't get treated. They silently spread the pathogen.
And it gets worse, right?
Yeah, because they might try to self-medicate with partial courses of black market antibiotics, which means they become living incubators for drug-resistant superbugs.
So how does PREMA solve for human shame?
By guaranteeing anonymity. PREMA has a 5-minute quick access mode that is entirely anonymous.
Oh, that's brilliant.
You told the investors, PREMA allows these individuals to get clinical-grade guidance, isolation advice, and even discreetly routed prescriptions without ever facing a human receptionist or a judgmental waiting room.
It provides a safe harbor for the people who need it most.
Yes, it plugs a massive, completely ignored hole in our global biosecurity by bringing the invisible, terrified half of the population into the triage system safely.
Which brings us to slide 16, the grand finale of your pitch. The call to action. You have to synthesize all of this, the public health urgency with the business opportunity.
This is where you summarize the monumental scale of the opportunity. You outline a concrete target for them. Deploy 5,000 kiosks across a specific region, like the UK.
Okay, let's do the math on that. 5,000 kiosks, handling roughly 10 consultations a day. That's what, 18 million annual consultations?
Exactly. You tell them even if only 10% of those 18 million consultations prevent an unnecessary GP or A&E visit, we save the national health system hundreds of millions of pounds instantly.
And you remind them of the triple-purpose financial model.
Right. It generates commercial revenue for the franchisees and investors. It subsidizes care for the disadvantaged because the profits can lower the cost of use in poor areas. And it creates a humanitarian funding loop for global health initiatives.
So you look the investors in the eye and you close with the reality of AMR. You say, the superbugs are already here. The economic drain is already happening. Let's build the firewall now before it becomes unmanageable.
It is such a strong close. If you structure the information exactly like that, moving from the biological reality of mild symptoms to the threat of AMR, exposing the flaws of centralized hospitals and rigid apps, and finally presenting the combinatorial AI and physical kiosk as the ultimate solution, you create a narrative that is impossible to ignore.
It shifts the conversation entirely.
It really does. It moves the room from passive panic about global pandemics to active engagement with an investable, highly scalable solution.
Now, to leave you, our listener, with a final thought to mull over as you build out this pitch.
Yeah, there is a concept buried deep in the source material about the long-term potential of these PREMA kiosks. It's the idea of a standalone intelligence network.
We briefly touched on this when we mentioned the kiosks have offline fallbacks and can run locally, right?
Right. But take that to its logical extreme. These kiosks are fundamentally designed to bypass the failures of traditional infrastructure. They can be solar-powered. They don't need continuous high-speed internet to run their triage logic.
So imagine a future where we face a catastrophic global blackout.
Or a total infrastructure collapse caused by an extreme weather event, or maybe a massive cyber attack on the national grid.
The hospitals go dark. The internet is totally down. Your smartphone is literally just a useless brick of glass in your pocket.
Yep. And in that scenario, the only reliable, functioning source of medical guidance on your entire street might be a solar-powered PREMA kiosk sitting outside the local chemist.
That is a staggering thought. It completely reframes the value proposition for the investor.
Completely.
Because when you pitch this, you aren't just asking them to invest in healthcare efficiency or pandemic prevention.
No. You're asking them to invest in the survival infrastructure of the 21st century.
And it brings us right back to where we started. When the traditional system breaks down, when the waiting rooms are overwhelmed and the lights literally go out, you need something else to light the way. You need a decentralized intelligence that can stand alone.
You need a firewall.
Good luck with the pitch. We'll catch you on the next Deep Dive.